Scoliosis is an abnormal curvature of the spine. Children develop scoliosis, but adults can develop scoliosis as well. We don't know what causes scoliosis. Some people believe that, especially when it comes to children, there is some genetic predispositions, but in adults it's just degeneration and aging. When the spine is in an abnormal position, people use more energy, but use more muscle energy basically to keep their posture, which leads to excess strain, muscle fatigue, and ultimately to pain. In children, when the scoliosis is very severe, it can impact their lung function as well. In adolescence, we do have certain markers that we look for. Usually in adolescence, when children reach a curvature that is greater than 50 degrees, we start to consider surgical intervention, especially if the child is not yet skeletally mature. In adults, it's a little different. It's driven predominantly by quality of life factors and the patient's disability. If the patient has significant positive balance, meaning their head is way in front of their pelvis and they're suffering from pain and it's limiting their daily activities, we then consider and offer the option of surgery. So in the old days, especially with cases of very early onset scoliosis, we used to treat children, even babies, with casting to try to basically mold and force their body to a more normal kind of alignment. To a certain extent, in very young children, we still use this method because we don't want to fuse or surgically intervene in very young children. When people think of scoliosis, they think of these rods, these Harrington rods, and these were straight rods that were basically attached to the spine using wires to try to force the spine to be as straight as possible. Obviously, this to a certain extent was somewhat capable of correcting the patient's curvature, but it didn't restore this kind of normal anatomic alignment. The way we do things now these days, we use what are called pedicle screws. We place those in the vertebra, and using very kind of specifically contoured rods, we create a very normal physiologic alignment of the spine and fix basically those screws to these rods, and they hold the alignment. Using kind of more modern techniques such as spinal navigation, which we kind of sometimes colloquially call GPS for the spine, we're able to place screws in a much more efficient and also accurate manner than ever before. As opposed to using our anatomical knowledge in the patient in front of us, we use a computer system that's combined with imaging to place a screw extremely accurately and just in the perfect spot in the bone that we would like. What that allows us to do, not only is that safer for the patient, but it also allows us to basically use that screw more effectively to restore the patient's alignment, and which once again allows us to correct the patient's curvature much better than we were ever able to with the Harrington rods and simple wires, which allows the patient to recover faster and get back home sooner. In my laboratory, we use something called machine learning. We use the computer and teach the computer how to recognize medical images of the spine. We train this computer using hundreds, if not thousands, of examples of scoliosis and other kind of spinal diseases. And then we ask the computer, what is the best way to treat this specific patient? So as opposed to just relying purely on my teaching and my own personal knowledge, we're able to rely on the knowledge from thousands and thousands of cases and tailor that knowledge to this specific patients to create a very personalized approach, but also a very data-driven approach to basically provide a more accurate diagnosis for the patient. This kind of work can only be done at this big academic center because you require thousands and thousands, potentially millions even, of images and cases to once again train these kind of computer networks to be able to help us. Being at a place like UCLA is great because not only do we get to treat patients with these very complex spinal disorders, but it also allows us to do research. And the ultimate goal of research is to further and advance the care even more. So I certainly hope that 10 years from now, I'm going to put myself out of business in a sense by creating technologies and ways to treat patients that allows us to treat these complex curvatures in a less invasive manner, in a more efficient manner, and with a higher degree of success than we were ever able to. I think people think all fusions are kind of the same, and they're very different depending on the specific patient characteristics. I think if you're just having back pain without a serious spinal deformity, a fusion may or may not be the right answer for you. For patients who have significant degenerative scoliosis, that significant sagittal imbalance or coronal imbalance, I think these surgeries have been shown, through our research, that they can have a profound effect on reducing your pain and reducing your level of disability. In the end, what these surgeries allow people to return to that level of life that they would want, which means more active and participating in exercise and activity that they previously were not able to because of their spinal deformity.